Good morning.
Good morning.
Today, I have some questions for you. So, we're just going to it's a consult with me episode, but it's also just a short episode on perimenopause
Yeah.
because right now, first of all, we have a lot of new patients coming in suddenly with perimenopause. And I think a lot of it's all over social media. So, women are realizing they are in perimenopause, that there's a reason for their lack of sleep, weight gain, mood swings, depression. You've been doing this for so long. I first started dealing with perimenopause when none of my friends were looking at it at 44 years old because I had access to you. However, at that time in the office, you weren't treating people really for perimenopause, just menopause.
I would differ with that statement.
But it wasn't like it is now. My point is the
I
awareness.
agree.
Yes.
Not like it is.
There
now.
was maybe a few of us coming through, but not like now.
Right.
Wouldn't you say that?
Yeah, absolutely.
The awareness.
And part of that is social media, and part of it is progress.
Yeah.
People are more aware. So we're also dealing with more menopausal patients than we used to. But that's the nature of the beast. That's as I've grown older, my patients have grown older with me, and they have different problems now than we had 10, 20 years ago.
But this new surge of patients is perimenopause.
Yes.
And we've talked about the PHRT before on the podcast, and those episodes do really well because I think we're addressing possible treatment for perimenopause.
Yeah.
But I just want to go over, there's also some men out there now on social media that are very vocal about now women having an excuse for their bad moods and they're calling it perimenopause. And it's almost like a bit, like a comedy bit.
There's nothing funny about that.
No, I know. And so there's been a lot of pushback. And also on social media has gotten so mean that women now are getting criticized by other women and men for just even taking their health, the way they're feeling, their hormones, and being proactive. I don't really think there's one thing to say about perimenopause. That's going to make everyone realize it's real. But I'd like for you to go into what firsthand with patients coming through, especially the depression part of it, because it's very real. And I want you to speak to that today.
I think I'm glad you put it that way because it is real. It's a real thing. So menopause, by definition, is something that occurs to women, and they are called menopausal, described as menopausal, if they have not had a period for a year. And that's a little late in the game because so much of the time, for maybe 5 or even 10 years before that 1 year is reached, patients are symptomatic and patients are struggling with it and their health is deteriorating. And although we have this definition of menopause where it is, as I just said, we have other ways of looking at that when they haven't quite reached that position of stopping periods completely, but hormonally they are lacking estrogen and progesterone and perhaps a little testosterone, which is causing them some symptoms. But that's all premenopausal also. It doesn't have to be a measurable change in hormones for those symptoms. So a lot of the time, a patient will have symptoms of perimenopause, meaning perimenopause means just is around the time of menopause. So around the time of menopause means time before that, the time of that happening in that 1 year, and all the time afterwards. Those are all described as time. The certain areas they're all realities that they're happening. What I think is happening is that although the blood levels may be normal, it's not normal for that patient. They have had a decrease in the amount of estrogen.
Yeah.
Or they've stopped ovulating or not ovulating regularly, so there's not the normal cycle of estrogen and progesterone. So this is very real. They have the symptoms that you're talking about. It's the weight gain, it's the depression, it's the moods, it's lack of sleep, it's foggy thinking. It's all there for as much as 10 years before they become officially menopausal. That's what we're paying attention to now. And it's hard to know whether or what treatment is right. So a lot of the time we are using trial and error to treat patients, whether it's trying to get them still to ovulate and go through the normal menstrual cycle.
Well, a lot of women come in, I think, because they've heard testosterone, perimenopause, testosterone. And then there's other people that are like progesterone. This is what I need, progesterone. So they're already coming in self-diagnosed.
Yes, which doesn't always help.
So the testing process to look at everything, and then, like you say, trial by error.
Yeah, and the testing process might not tell us anything. So a lot of it is just listening to the patient and what are your symptoms? What can we help with? Let's try this.
And the perimenopausal patients are the quickest to get relief.
Generally, yes.
Yes. So that's what's good. If you're trying something,
right,
they'll a few days later be like, oh my God, this is it. And they're happy right away. They're easier almost to solve.
In a way, but sometimes it can be more difficult because it's not this absolutely straight line of lowering estrogen that those perimenopausal patients have. They may go down, they may come back up. They may ovulate twice in a cycle. And so they're a problem because they often have irregular bleeding. And that's a major nuisance.
Or heavy bleeding.
And heavy bleeding, yes. That's called dysfunctional bleeding. It's bleeding without ovulation. And also, if they're not ovulating, they're not producing progesterone, they're building up the lining tissue of the uterus, the endometrium, which causes them to have irregular bleeding, whether it's spotting or whether it's very heavy bleeding.
Yeah.
So it's a moving goalpost.
If you could change something about testing, and let's look at OBGYN practices everywhere, what age do you think some of this testing should start and treatment should start? If you're looking at whole health, female, whole health, hormones and longevity.
40.
And what tests would you want them to be having?
There's a battery of hormonal tests we look at, and whether it's hormones coming from the ovary, from the adrenals, from the pituitary gland. These are all things that we would look at. But the important thing is listening to the patient, because it's not always clear from the blood tests what is going on, because it's variable. And in a normal menstrual cycle of 28, 30 days, those hormones are changing daily. And so we can't isolate a moment in time in that cycle to say, okay, this is too low a level, or this is too high a level, because we don't know where they are in the cycle. What's normal in one part of the cycle is not normal in another part of the cycle. And then there are, of course, the patients that aren't having cycles and maybe building up endometrium but not bleeding. So it's absolutely on a individual basis that we have to treat. We have to try to treat the patients. And once they become menopausal, they've got to that point where there is ovarian insufficiency. The ovaries are just not working enough or well enough to produce good amounts of estrogen and progesterone. They become much easier to treat because now we've got a stable, as they say, a solid goalpost to supplement. So I think getting hormonal levels on patients at 40 is a great idea. Just let's see where they are. And at least by 50, getting a bone density study of some sort.
Yeah. If it's in their family, they should probably get it sooner.
Yeah.
osteoporosis, right? Yeah.
So we've definitely expanded our treatment of patients to a younger age.
Yeah.
Because
I think you've always had it available. There just wasn't the surge of people wanting it. And now everybody wants it.
Right.
So I think it's great.
The problem with the treatment is that if we try to treat what's missing, which is the estrogen or the progesterone, we may not be able to treat it because the patient's ovaries are still working some of the time, or they may be misfiring. So there's still these variable hormonal levels. And if we're giving them, maybe we're complicating that issue a bit. So what sometimes can happen is we'll supplement testosterone, because testosterone is not really, in my mind, a replacement hormone.
Yeah.
It's really a supplement.
Kind of stands alone.
It stands alone. It doesn't increase the risk, but it can do so much to make a patient feel better. That's generally what we want to do.
Yeah.
But it's fortunately people are becoming more aware of this.
Yeah, I think so too.
The patients are aware of it, and unfortunately they're ahead of the doctors.
Yeah. I get that sometimes that could be a bad thing because there's so much information out there, and that's a good thing in that there is so much information, but it's a bad thing in that it's never a one size fits all. So what you read about for one of your friends, or what you talk to someone about, or you read about on social media, isn't necessarily what's going to fix them. Yeah. So anyway.
But they should still try to fix it.
Yes.
They should still seek that guidance.
Yes. Thank you for doing this today.
My pleasure.
Good job, Dr. Turner.